Hi everyone, welcome. I am Dr. Adrienne Gentry, a board certified OBGYN and reproductive endocrinology and infertility specialist. I work for the Florida Institute for Reproductive Medicine in the Jacksonville locations. Today, I wanted to talk to you about endometriosis and infertility. I think it's really important for you all to hear these two statements. Not everyone with endometriosis experiences infertility, and not everyone with infertility has endometriosis. So at the beginning, I want us to talk about what endometriosis is. So let's explain that. So each month when a woman gets a period, they bleed the uterine lining out of the vagina, right? Well, we also bleed out of our tubes. It's called retrograde menstruation. Some of us bleed a little bit out of the tubes, some of us bleed a little bit more. And women without endometriosis, the blood that we bleed out of the tubes gets broken down by our body. However, the women who do have endometriosis, that blood that we bleed out of the tubes sticks to things. It can stick to the bowel, the pelvic sidewalls, the fallopian tubes, the ovaries, the bladder. It can stick to anything that it comes in contact with. And that blood, again, which is our uterine lining, is just response to our hormones that our body makes every month. So let's walk through that. Let's talk about that. So every month when we start our period, our body realizes we're not pregnant. So the brain stimulates the ovary to grow another egg. That egg makes estrogen. Estrogen is what grows a brand new lining in our uterus. Once the estrogen gets to a certain concentration, the brain stimulates that egg to ovulate, and after we ovulate, we make progesterone. Progesterone acts on that lining that we just thickened from estrogen and makes that lining like a nice, fluffy, comfy pillow for that fertilized egg to implant into. If we're not pregnant, about 10 to 12 days after we ovulate, those hormones drop significantly, and that's what makes us have a period. Well, in women with the endometriosis, where that lining that keeps getting bled out of the tubes that sticks to things, that lining responds to the estrogen and progesterone as if it was inside the uterus. So what happens is as estrogen levels rise, the lining in the wrong places in the pelvis start to thicken. And then when progesterone is released, those areas start to get fluffy. And then you're not pregnant, and that lining that's in the pelvis can't shed, it can't go anywhere. And it just causes this constant pelvic inflammatory environment. And the symptoms that occur from these lesions in the wrong location are multiple. So a lot of women have really painful periods, meaning a few days leading up to bleed, which is from that drop in progesterone. You start to experience really bad pain in your back, deep pelvic pain and cramping. Some women experience pain with intercourse. Some women experience diarrhea while they're bleeding. There are all kinds of symptoms that occur from endometriosis. But some women can have really extensive endometriosis and not have any pain at all. Or some women can have a lot of pain and hardly any endometriosis. And so that's the hardest part about endometriosis, is that really the only way of knowing a woman has endometriosis is by doing surgery and is doing a diagnostic laparoscopy and looking in. Unless a woman has what we call an endometrioma, which is essentially the blood collecting in the ovaries, and it has this specific look on ultrasound. So if a woman has an endometrioma on ultrasound, then we know for sure they have endometriosis. Otherwise, it's really difficult to tell unless you go in with a camera and look. So when it comes to the patients who come to see me for a fertility evaluation, they've gone months and months and haven't been able to get pregnant, I ask them specific symptoms that they occurred during their cycle. I want to know, do they have pain with their periods? When does the pain start? Does medication help? And I ask all of these questions during our first intake. Generally, endometriosis doesn't cause irregular bleeding. It doesn't cause heavy bleeding. It's mostly a pain and inflammatory symptom that you experience. If patients don't tell me they have any of that, then I don't generally recommend we move forward with surgery. I just go through my typical fertility evaluation, and one of those is checking the tubes, right? The fallopian tubes. In order for pregnancy to occur, the sperm and the egg have to get together in the tubes. And so I'm always checking the tubes with a hysterosalpingogram to see if the tubes are open. If the tubes are not open, then I wonder if the patient could have endometriosis causing scarring of the tubes, right? So that's one of the ways that endometriosis can prevent pregnancy. So the endometriotic lesions can attach to the tubes, or just cause scarring, which causes the tubes to be scarred and prevent the sperm and the egg get together. So that's one way endometriosis prevents pregnancy. The other way is that if the tube is scarred at the end of the tube and it can't grab the egg that has been ovulated, it can also prevent pregnancy just because of this constant inflammatory state in the pelvis. It's just not a great environment for the embryo to implant and grow. It also a lot of times causes a decrease in egg number because, again, these endometriotic lesions and this inflammation causes a destruction of the eggs. So that is really the basis of how endometriosis can affect fertility and future pregnancies. When it comes to surgery and endometriosis, anytime someone has endometriosis in their ovaries, removal of that endometriosis will always reduce the number of eggs you have. So generally, I really tell my minimally invasive surgeons to try to leave the ovaries alone if possible. However, if there is a very large endometrioma, it is generally recommended that that be removed. But again, generally, I try to leave the ovaries alone to leave the eggs intact for the patient for the future. In regards to surgery for endometriosis, the data says that if you have stage 3 or greater endometriosis, which is, again, the number of lesions in the pelvis, removal of those lesions will significantly improve the chance of pregnancy moving forward, usually within 6 months of surgery. If you have a few endometriosis lesions, removal of them doesn't decrease your chance of pregnancy, but may not improve chances as much as if you had more lesions present. But definitely removal significantly improves your pain and discomfort. So, all in all to say about endometriosis and fertility, I want you to remember my 2 statements. Not everyone with endometriosis has infertility, and not everyone with infertility has endometriosis. Listen to your body. See a doctor who listens to you, and really any fertility doctor you work with should be working with you as a team. And that's how I approach all my patients. We are a team. I listen to what they say and what they want, and we go from there to give them, what they ultimately want, which is a baby. All right, take care, and thanks for listening.